Good morning and welcome to Facebook Live. I'm Dr. David Cohn, the Chief Medical Officer of the James Cancer Hospital at Ohio State, and it's a pleasure to be here again on a weekly installment of the James Cancer Hospital's Facebook Live event, talking about COVID-19, how it impacts our cancer patients, and the practice of medicine. And over the last 2 weeks, we've tackled topics of COVID in general. Last week, we discussed the immune system and the immune system's role in fighting off COVID-19 and how cancer patients and the treatments of cancer impact the immune system as well. Today, we're going to turn it around a little bit, and instead of talking about COVID-19 as a condition or a disease, we're going to talk about how COVID actually impacts the practice of medicine. And today, we're going to discuss telehealth. Telehealth is an interesting topic to discuss because telehealth is something where I think in general, you can think about this as being a type of healthcare delivery that's instead of being provided face-to-face in a traditional clinic or hospital-based visit with a provider or a healthcare professional. Instead, the visit's actually occurring by a variety of technological means. That can include a telephone. It can include a video as well. And telehealth has been something that I think across the entire healthcare community we've been trying to tackle for many years, trying to figure out how we can deliver healthcare in an individual's home without having them come into a clinic to reach out for a face-to-face visit unless that's absolutely necessary. And because of COVID-19, the overall goal, as we've talked about before, was to limit somebody's environment, control the environment to minimize the chance that they could be infected with COVID-19. And from that standpoint, the overall perspective was, what can we do to try to decrease the traffic that comes through a hospital system? What can we do to decrease the need for a patient to actually need to be in a hospital or in a clinic? And therefore, what are the means by which we can deliver appropriate healthcare to individuals without having them come in? And that's how you define telehealth. So COVID-19 has really escalated the process of trying to develop a telehealth strategy for healthcare systems across the country, and certainly at the James Cancer Hospital here in Columbus. And so let's think first about, what telehealth might look like. What are the type of cancer visits that can be virtual? Virtual visits meaning the telephone or video, and which ones can't. So here's the way I think about it, is that if there's something that requires a healthcare professional to actually have a face-to-face visit where there's an examination of something that you can't see on video, or in an individual where having the personal connection of somebody in a clinic with you really is important, that can't be done by a virtual visit. And likewise, if treatment needs to be done in the operating room or in radiation therapy or with infusion of chemotherapy, obviously those are things that cannot be done remotely as well. They have to be done through telehealth. So in this circumstance, we're in a position where you can look through a patient's chart and try to figure out, is this an individual where we have an option for telehealth, or is this an individual where we should not be doing telehealth, we should be doing a face-to-face visit? So there are a few types of visits that have to be done face-to-face. Beyond those, the general structure is that we should try to do those virtually by telehealth to minimize the traffic that comes through the hospital, to minimize the risk of any individual getting COVID-19, and especially in that really vulnerable population of cancer patients where we know that their complication rates from getting COVID-19 are much higher. So trying to control that environment is key. So what has the James done to try to accommodate this changing environment to make sure that we can maximize the ability to do telehealth? Well, first and foremost is once we began realizing that this is a necessity, we actually placed webcams throughout our clinic systems. These are things that we didn't always have access to. And so very quickly, we set up webcams in our clinics, made sure that our providers and other healthcare professionals had webcams hooked up to their computers as well if they were working from home, for example, to maximize the ability to have the video visits. And likewise, we made sure to try to identify opportunities where our patients could engage through the webcams. And here at the James Cancer Hospital and at the Ohio State Wexner Medical Center, we use Epic as our electronic medical record vendor. And so it's important that our patients sign up for a product called Care Everywhere as part of Epic, and that allows them to use their medical record as a means by which to communicate through video visits. So those things had to be set up structurally. But we realized that there were many patients that didn't have the ability to have, that didn't have a computer, that might not have a tablet, that don't have a smartphone. And in those circumstances, these are patients in whom doing telephone virtual visits would still be very appropriate. And likewise, for patients that had the capacity to do video visits, but didn't have care everywhere as part of their EPIC, as part of their medical record, we're actually contracted with a third-party vendor as well to be able to provide these types of video visits for individuals that don't have care everywhere. So we really looked at the overall structure of our patients and tried to determine in whom it would be appropriate for a face-to-face visit, a telephone visit, and a video visit, whether that's through our third-party vendor or through Care Everywhere through our EPIC product. And it's really important to note that all of these types of products that we're using to perform the televisits are safe. And I think that patient privacy and protection is a really important issue when you're thinking about these virtual visits, because the concern is that could somebody hack into the video chat? Could somebody overhear the protected medical information that's being exchanged by the patient and his or her healthcare provider? But it's really critical to note that everything that we use is called HIPAA compliant. That's our patient protection and confidentiality law that's federally mandated. So they're all very appropriately used to minimize, to avoid any potential risk for disclosure of protected health information. So these are all safe, and we're guaranteeing the patient protection and privacy that we always have, whether it's a face-to-face visit or a virtual visit as well. So these are really important things to remember. So how does a telehealth visit work? Let's talk about that just in terms of operationally. So as I said before, that all of our clinics are going to go through the list of patients that are upcoming, whether a new patient or whether it's a return patient or a chemotherapy visit, and try to determine what's the right type of visit by which we would actually have that visit occur. And so in this circumstance, we would say infusion visits or radiation visits, those are still face-to-face as they've already been scheduled. But if a patient can have a virtual visit, then we try to figure out what type of technology do they have access to. If they have a telephone and that's the limit of their technology that they have available, in that circumstance, then we'd have a telephone visit set up. And we would arrange for a time, like a clinic visit, where your healthcare provider would reach out to you and make a phone call and have a conversation and document that in the medical record. The other thing that's really important is, regardless of what type of visit it is, whether it's a telephone or a video visit, in this circumstance, we would also make sure that by the end of the visit, we're not just trying to address a medical condition or concern, but rather the question becomes, did we achieve what we needed to achieve, or is there more information that's required? Because if that's the case, then a patient's going to have to come in for a physical face-to-face visit. So I think that's the other really important thing, is because a visit starts as a virtual visit, it doesn't mean that's where it ends. And I think in this circumstance, the goal that I at least try to achieve, and I'm sure that most physicians and providers do as well, is by the end, if there's more information that's required that can't be done virtually, then a patient comes in for a face-to-face visit. And that's really, really important. So if a patient has more than a telephone, then we try to figure out what's the right means by which we can communicate through video chat. And if they've signed up for Care Everywhere, very often that's done by OSU MyChart, where there would be a time that's established. The patient would basically be with an appointment time, and they would log into their MyChart, and the physician would, or the provider would, log into their medical record on their side of the portal, and then there would be a virtual video communication. If they don't have MyChart, if they don't have that EPIC product that we talked about, in that case, that we would use a third-party product by which the physician basically puts in a cell phone number into this secure portal. It would send a text to the patient, and the patient would then click on that text link, and up would come a screen, and then the provider or the healthcare provider would be there on the other side communicating with them. And what this does, it allows a lot of opportunity. Number one, it allows this face-to-face interaction that we're used to in healthcare. It also allows us to be able to do some type of physical examination. If someone has a rash, for example, or if there's an incision that's being evaluated, you can use a cell phone or a tablet or a computer webcam to actually look at those areas to make sure that we can get a sense for what needs to happen in terms of treatment. And again, if there are things that can't be met through the video chat or through a telephone, then the patient would be scheduled for a follow-up face-to-face visit. And what we found so far is that the majority of the visits that we're doing since COVID-19 started are now virtual, which is, I think, just amazing. We've gone from doing a few virtual visits to, in under a month, having the majority of our visits now done virtually. And most of the patients are experiencing a high degree of satisfaction with these visits. It's obviously very convenient as well. And so in that circumstance, we're in a position to be able to continue to follow these patients virtually when necessary. But also, I think it's important that we're going to learn a lot of lessons through this COVID-19 pandemic that are going to last us on the back end of the pandemic to try to figure out what virtual visits look like in the cancer population after COVID-19. I think we're going to find that there are a lot of visits that we continue to do virtually just to minimize that transportation for the patient back and forth unless it's absolutely necessary. A couple more points, and then we're going to address some questions as well. Is that how do insurance companies cover virtual visits? Are these the same as in-person visits? There used to be a lot of barriers for billing of virtual visits. And in fact, it was because of COVID-19 pandemic, a lot of these barriers to being able to bill an insurance company have been broken down, such that now most insurance companies cover virtual visits just as they would a face-to-face visit. And I'd recommend that all patients try to work with their insurance providers to ensure that these are covered as well. But because of COVID-19, all of the challenges that hospitals and clinics have had with virtual visits have been broken down because that's in the best interest of our patients as well. Another question that people ask always is whether or not support people can attend virtual visits. So if you got a family member or a friend or someone that provides medical care at home to help you out, either to understand or to provide physical comfort and support, can they attend the virtual visits? And the answer is yes. So you can have as many people as you want to crowd around a screen in virtual visits. And we're in the process now of rolling out multiple individuals in different locations sharing that same virtual visit. So, if a patient is somewhere and a caregiver or a family member is elsewhere, those two individuals plus the provider can all be on at the same time as well. And then I think, again, an important point about virtual visits is what should patients be asking during virtual visits? And I look at that and say that patients should be asking the exact same questions that they ask their providers, healthcare providers, in a face-to-face visit. So ask the same exact questions. But I think most importantly, at the end of the virtual visit, the question that you want to ask your provider and that your provider should be asking you as well is whether or not all of the goals of that visit were accomplished in the virtual visit. Because if not, as I said, the fallback can always be face-to-face visit, set up a follow-up appointment in clinic in the next couple of days or week, and then that patient would be able to be seen face-to-face to finish whatever couldn't be achieved by that virtual visit. So I suppose in summary, virtual visits have really escalated in terms of their implementation because of COVID-19. We've learned a lot in a really short period of time about how to do these. As I said, they can be done by telephone. They can be done through the Epic. And I have to correct myself as I said something wrong. For OSU patients, it's through the My Health app. I made an error in stating the product. It's not My Chart, it's the My Health app, and I apologize for that. And then for individuals that don't have Epic, then it's also this third-party HIPAA-compliant product that's being utilized as well. So we're working to accommodate whatever is in the best interest of our patients and kind of adapting to whatever their technological capacities are to make sure that we're able to perform these virtual visits and continue healthcare despite and through this COVID-19 pandemic. So those were all the major points that I had. I'm going to take a look over here on the left and try to figure out if there's any questions that I can answer at this point in time. Someone had a question about insurance companies and what they're doing with these, and hopefully that was addressed as well, is that most insurance companies do cover virtual visits. Those that didn't start off covering at the beginning, many have now recognized the importance of doing this because it's in the best interest of the patients. I do want to follow up with a couple pieces of information from last week about the immune system. There were some questions that I wasn't able to get to that I just want to comment on. Someone asked a question about whether because COVID-19 affects the lungs, people hear a lot about pneumonia and needing to be on ventilators because of pulmonary or lung failure because of COVID-19. And someone asked a question whether lung tumors can aggravate whether COVID-19 can aggravate lung tumors and cause them to grow, or whether problems with the lung can make COVID-19 worse as well. And the answer to the question about whether or not COVID-19 makes cancer grow, the answer is no. So COVID-19 in and of itself does not cause cancer to grow, whether it's in the lung or elsewhere. And I think importantly is that, as we talked about before, COVID-19 in individuals that have baseline lung problems, whether it's cancer in the lungs, whether it is chronic obstructive pulmonary disease, COPD, whether they're smokers as well, these things do potentially increase the complication rate from COVID-19. So location of disease definitely can contribute to outcomes related to COVID-19. And the other general group of questions that was asked is whether or not individuals that have had cancer treatment in the past are still more susceptible to COVID-19. And I think in this circumstance, the answer in general is no. So once somebody has had cancer and cancer treatment, and that cancer treatment has been to the point now where the immune systems are recovered. So let's say there's a bone marrow transplantation and the immune system is back up to normal again, or whether it's chemotherapy that wasn't a bone marrow transplant, but someone's blood counts are back to normal after chemotherapy. In general, the immune systems are towards back to normal to the point where they should be able to fight COVID-19 appropriately, such that those patients should not be at increased risk for developing COVID-19 or complications as a result of the disease. So with that, I appreciate everybody joining me here on our third installation of Facebook Live. David Cohn, the Chief Medical Officer at the James Cancer Hospital. I hope everybody has found these informational. I apologize that I wasn't able to get to everybody's questions, but as I did this week, be happy to pick up some others next week when we do this again. So everybody be well, be safe, wash your hands, use hand sanitizer if you don't have soap and water. And again, hopefully we'll be out of this soon. Be well.